I take the opportunity and welcome everyone who joined us this evening. And I think let me first introduce myself. I'm Dr. Queen Ramarasi, and tonight I'm not going to waste your time, guys. We have Prof. Saleigh Adams. I know Prof from medical school, and I must say I had the privilege of spending some time in my fifth year at Red Cross. And for the first time, I think I was inspired. You're one of the first mentors that actually sort of shaped my path into medicine. And I'm so glad to have you with us today. And of course, the reason why most people join today is because we want to learn how do we actually become plastic and reconstructive surgeons. And the interesting thing that I think you are one of the people that are in this country, I think, do craniofacial. In the beginning, I thought it's maxillofacial, but it's actually craniofacial. And that really fascinated me a lot when I was still a student. So I think we'll get to that. But Prof, I'm going to hand over to you to just say hello to everyone, and then we can start.
Slideshow. This is a talk that I gave to the Surgical Society in April. So I'm gonna do that talk again. And so the talk is titled "The Life of a Plastic Surgeon." And first off, I'm just gonna start with a little introduction. And Queen was very kind to introduce me. My name is Saleigh Adams. I'm the head of the Division of Plastic and Reconstructive Surgery at the University of Cape Town. In fact, I sit in the David Davies chair, which is an inaugural chair that was launched in 2019, and I was the first recipient in 2022. Currently, all divisions at the University of Cape Town are represented by chairs, certainly in surgery, with the exception of urology. In fact, they're now trying to create the Desmond Tutu chair. So the chair comes with a great responsibility. The University of Cape Town is currently ranked at 133 in the world, and is the top university in Africa, certainly in Africa. And that's the overall ranking. But in certain areas like infectious diseases, we are ranked in the top 20. And our medical school is and was for a long time in the top 50 in the world. So we're doing very well from a university point of view. Now, plastic surgery is the smallest division in surgery, and it goes against international trends. In fact, it's the surgical specialty currently which has one of the greatest demands to train in. And we find it very difficult to meet that demand because, we kind of too slow in trying to create positions for all our aspiring new surgeons. And in fact, one of the reasons for that was, for many years, plastic surgery was I would say, the best kept secret in surgery. And it of late, with the advent of social media and Hollywood, Bollywood, there's been a lot of focus on plastic surgery per se. It's a multifaceted discipline. We are the true general surgeons of surgery because we operate everywhere in the human body. And it's a fascinating discipline, and it concurs with pop culture, if I can say that, and what's happening in the world today, especially with people and the need to improve self-image and the quality of life. So that's just a basic introduction, and I'm going to try and answer some of your questions, Queen, in the talk. So the life of a plastic surgeon is a great one. I can assure you. I trained and I started my training in surgery in the late 90s in the UK. I was on the FRCS, or the Fellowship of the Royal College of Surgeons, rotation in the Greater London area. And then I came back to South Africa in 1998 and started my surgical career in general surgery. And in fact, I was dead set on becoming a vascular surgeon. And towards the end of my tenure, my 5-year tenure as a registrar in general surgery, I was offered a fellowship in vascular surgery in Dublin, Ireland. And two of us, in fact, a very famous guy now in Cape Town called Martin Fawley, the two of us was offered this prestigious scholarship or fellowship opportunity, and he went and I went to plastic surgery. Can you believe it? And I started from rock bottom and did another 5 years of training as a plastic surgeon. So I don't expect, there's not many people who do that, but I did it, and I'm not sorry. And you'll see why in the next few minutes. Lots of misconceptions about plastic surgeons, and one of that is the acquisition of fast cars, the pursuit of the perfect body. And what is the perfect body? That's very debatable. And there's been and evidence has shown that there's been increasing attention on beauty and perfection over time. It's rumored that in 2024 alone, there was 38 million cosmetic procedures performed worldwide. And that was a 19% increase in cosmetic procedures since 2019. So it's on a massive increase. And it's not only performed by plastic surgeons. In fact, it's performed by disciplines allied to plastic surgery. What was the top 5 cosmetic procedures in 2025? Well, rhinoplasty, something that I do a lot of, gynecomastia correction. We all know about liposuction, eyelid surgery, penoplasty. These were the top 5 surgeries according to the American Society of Plastic Surgery in 2025. What is the top 5 minimally invasive procedures? And here I say even GPs and people who've done diploma courses, dentists, etc., nowadays are doing Botox and fillers and skin resurfacing, as well as laser treatments. So it's become very commercial. If you look at the top 10 highest paid doctors in South Africa for 2024 and 2025, you see that the chief of surgery, and here, but orthopedic surgery is right on top there, and plastic surgeon only comes in at number 4 on our Forbes list, but it's number 2 on the American Forbes list. So from an earning point of view, we're doing very well. We interact with every single discipline, and we operate on every part of the human body, so we go everywhere, basically. So we kind of share our hand surgery with orthopedics, we share head and neck surgery with ENT, we share craniofacial surgery, which I do, with neurosurgery. We share maxillofacial surgery. We do lots of maxillofacial trauma. We share breast surgery with the general surgeons, and of course we do a lot of reconstruction with the gynecologists. So what really is plastic surgery all about? Plastic surgery comes from the Greek word plastos, which means to reconstruct. And 90% of what we train to do is not cosmetic surgery. It's reconstructive surgery. And here, like I said, we operate everywhere in the human body. We operate in the head and neck area, in the trunk, the abdomen, the pelvis, the limbs, etc. And of the earliest descriptions of plastic surgery was in the Shushruta in India around about 800 BC. And then modern plastic surgery really evolved from the great wars in the 20th century, World War I and World War II, when modern plastic surgery really came to the fore with the result of massive injuries and burn injuries as such. And here you can see that gunpowder changed warfare, and it also changed wounds. And so plastic surgeons or surgeons with a soft tissue skill and a three-dimensional ability and the ability to be innovative had to come to the fore. Here we see Tagliacozzi was an Italian surgeon, and he did the first nasal reconstruction surgery in the 16th century. And you can see there that he did this reconstruction on a leper. And at that stage in time, they lifted a soft tissue from the arm, and they covered the nose, and they used a special splint to hold that in place for a few weeks before they could separate that allowing the blood flow into the soft tissue and to be incorporated so that that flap could live on the nose over a 3-week period. So there's been many advances in reconstruction, improvements in the transfer of vascularized tissue over time, tissue regeneration to produce bone, cartilage, skin, etc. We've brought in laser surgery nowadays for pigmentation, for rejuvenation, and a lot of you will know that we can actually remove tattoos by using lasers. There's been lots of advancements with wound care, especially with regards to negative pressure wound therapy. And then, of course, implant technology has improved a great deal. And the implants that we use now, including implants that they use in orthopedics, are very inert and don't cause much of a tissue reaction. It all began here with this vacantry mouse in 1997, where we used one of these lab mice, and they grew ear cartilage on the back of the mice. The mouse was like a scaffold, and this is where tissue regeneration really started to happen in a big way. So advanced wound care is worth $36 billion, and a lot of it we actually use nowadays in reconstructive surgery. We're using bioengineered skin, not only in burns, but in all massive soft tissue injuries. Most of you would have witnessed or seen the use of negative pressure wound therapy. We've now at the next level with regards to antimicrobial dressings. We're using silver, we're using copper. In fact, the story around silver started in the 17th century, where the Maharaja from India would travel around the Cape from India to the UK to meet the Queen of England. And what they noticed was the water never went off because the water was stored in a silver urn. And this is how silver was born. And we started using silver sulfadiazine and silver nitrate on massive burn wounds in the First and Second World War. And now we're using dressings like Aquacel AG and Acticoat, which are in the form of silver ions and in a very technologically advanced way. So this has become a $36 billion industry, and we now at the forefront here at UCT. We will be opening up in the next year or two the very first state academic advanced wound care unit, where our patients can be treated in an ambulant way, and we can use all these fancy and technologically advanced products to their benefit. Cleft surgery, one of my fortes, and this is how Queen actually met me. I do all of most of the craniofacial surgery at Red Cross, as well as with the Smile Foundation of South Africa, and I also travel with Global Smile and Operation Smile on international. We don't call them missions anymore; we call them initiatives. As Queen was saying earlier, I do a lot of craniofacial surgery, and this is a child born with what we call trigonocephaly, which is a premature fusion of the metopic or frontal suture. And you can see that they tend to have a triangular shaped head, not a nice, beautiful round head. Okay, and there's pressure on the frontal lobe of the brain. As we know, the frontal lobe is responsible for memory, reasoning, judgment, insight, intelligence. And so we had to, number one, create space for that brain to grow in, because we know that in the first year of life, that brain grows faster than at any other time. So number one priority was to create space for the brain to grow in. And number two was to create as much of a normal shape as we could as possible. And here you can see that I've actually advanced the frontal orbital bar to create space for the brain. And we do some cranial vault remodeling. The neurosurgeons actually do the craniotomy for us, and they take off the cranial cap. And then I actually, like a jigsaw puzzle, I osteotomize the bone and put it together like that into a nice round shape. You can see the space there that we've created for the brain, beautiful. And instead of having a triangular shape, the child has more of a round football shape, which is in keeping with what society wants. So plastic surgery continues to grow. We only at number 4 on the Forbes list in South Africa. And according to research by our national society, The local market here is in line with global trends. What we have seen over the past 10 years is an increase of 780% in non-invasive procedures. And that's not because of us primarily. We've seen a 128% increase in breast procedures, yet we're still the minority. So in that way, we're moving away from global trends in South Africa or in sub-Saharan Africa. There's still a massive demand to train in plastic surgery. In fact, every other day, there's someone who writes to me requesting information on how to get or to train as a plastic surgeon. And I usually write back to them. I have a kind of, a letter which I send to them, a standardized version, saying that you need to train in general surgery for a minimum of 18 months, at which time you need to, during that time, write what's called your surgical primaries, which is your basic sciences, just like when you were in first and second year at medical school. So that's anatomy and applied physiology. And then you need to spend approximately a year in general surgery, of which at least 3 to 6 months need to be spent in intensive care. And you need to do one of either general surgery or urology, orthopedics, for 6 to 12 months, at which time this will qualify you to write your surgical intermediate exams. So once you've passed the surgical intermediate exams, and if you pass everything, that will be a minimum of 18 months after your community service, then you will qualify to apply for a registrar position in plastic surgery anywhere in the country. And what used to be 8 university training institutions is now 7. Unfortunately, quite recently, we've lost the Nelson Mandela University in the Eastern Cape. We furiously trying to get that up again, but at the moment we have Pretoria in University of Pretoria. We have the University of the Witwatersrand, and we also have I can't remember the exact name now. Maybe Queen can help me, at Medunsa, and yes, that's right.
SMU.
Surgical Science SMU, and then we have the Free State University, which is still running, as well as Stellenbosch University, and ourselves, and the University of KwaZulu Natal. So we 7 functioning university training institutions. And the training degree is a minimum of 4 years, but since 2020 they recommend up to 5 years. But it depends on how you function, how you perform in your various years. If you've got a lot of experience, you usually go through quite quickly. But if you don't, then it could take you as long as 5 years from the time that you actually join the program. And for those of you who are very junior, you actually do earn a salary when you work as a registrar. You're not like an undergraduate student, you're a postgraduate student working as a doctor, training as a doctor. So we did a study about 2008, and at our institution, the University of Cape Town, the average age at qualification was 33 years and 5 months. At Wits, it was 32 years and a few months. So it seems like a long time, but I can assure you that you are working and training at the same time. So it's not like, you have to fork out lots of money to train. It is, like I said, very sought after. But yeah, if you are committed, I suggest that you contact the various departments, try and do an MSc, maybe try to do some research and get that primaries under your belt as fast as you can. Get into a structured general surgical program, at which time you'll qualify to do the plastic surgical intermediates. And then, of course, you can apply for a training post. What has happened recently is that we haven't had the opportunity to extend our paying jobs. So there's even people who are applying for what we call supernumerary positions. That is people who do have financial capability or who are sponsored, for instance, um, coming from surrounding countries as well as from in our own country, if they can support themselves in terms of accommodation and food, etc., then they can train as well. But that's something that we can talk about when they do apply. um, Unfortunately, we haven't, and we're working furiously at this, trying to increase jobs, but in the current economic climate, it's becoming increasingly difficult to do that, especially in the niche fields like plastic surgery. At this point, I think I'm gonna open up to the floor and ask anyone to for if they have any questions, or any one of you who are interested in this field, please feel free, and I can try to best inform you during the next few minutes.
Thank you so much, Prof, for that insightful. I think all of us, when we come into varsity learning about plastic surgery, we know about the Hollywood surgery, plastic surgery version of it. But the interesting part, I think the reconstruction is the most fascinating thing that I think for me, in my experience, was the coolest thing I've ever seen. And I'm sure I speak for many others. So, guys from the floor, I'm going to ask you, because I think we have a couple of minutes with you, Prof, to please put your speaker up and ask your question, or type your questions for us while we still have Prof with us. From my side, Prof, what I wanted to actually find out, how many plastic surgeons are you currently training in UCT at the moment? Like intake wise, how often can you take in new registrars there?
Okay, so on average, at the moment I have 9 training posts, of which 5 are substantive. That means they paid posts, and 4 are supernumerary posts. So I've got a big footprint in Africa and the Middle East. So I train. I like to train people from from areas where they don't have those facilities, and I'm also in the process of creating an African pediatric fellowship. Um, so those candidates usually occupy supernumerary positions. On average, a job comes available every 1 to 1.5 years in the paid situation, and of course we have to wait for people to qualify as they come through. Um, I can tell you for the last position there was 155 applicants, of which after the elimination questions we had 119 people, and then after shortlisting we were down to 12, and that was for one position. So it's very, very competitive, but it assists the discipline, because that selection bias gets us to take very good candidates, and so we generally find the people who do come in, not only do they have the minimum requirements like the surgical intermediates, but they also have courses behind them. They have literature, or published literature behind them, and they have a wealth of experience in actual surgery. So they've been in surgical positions for 2, 3, sometimes 4 years, before they actually come across. So we do have that luxury of being able to select very good people, because we are in demand. But I think it's very frustrating for a lot of people, and there's this growing, increasing demand, especially among local candidates, where they prepared, and they're so desperate to come into the field that they prepare to fund themselves for that 4 or 5 years just to train in this discipline.
Hmm. Okay. And then another question, like for people that are maybe they have intermediates, they have primaries, they have Gen time, they're ready to apply, or okay, they become a successful candidate and they get into the rich post. Navigating an M-Med and writing your FC. So I'm assuming if you already come in with your intermediates, then your focus can just be on finals,
Yes.
learning the skill, and then just doing the M-Med. But we know that a lot of registrars struggle because most of them would finish their FC's exam and then the M-Med is not done on time. What would be your advice as someone who's really experienced and has supervised inmates in terms of helping registrars be able to complete on time at least?
When would just say that last part again? When would?
So what would be your advice to registrars so that they can finish their M-Med component with the FC final exam on time?
Yeah,
Because the M-Med and the FC, most registrars struggle that some of them
yeah,
actually finish the FC by the
mm,
end of 5 years, but the
yeah,
M-Med,
yeah.
it's not done.
So what is coming, and I was one of the last few that didn't have to do an MEd, which from my side was a disadvantage actually. You mean if you got an academic base, then you want to do that. But nowadays, since about 2010, I think that one needed in order to register as an independent practitioner in South Africa in all surgical disciplines, you need to have not only the fellowship from the College of Medicine of South Africa, but you also need to have an MEd from your own university. And at the present moment, I'm just, putting it out there so that everyone understands how it works. So the MEd is a research degree, and and that goes hand in hand with your fellowship, which is like a diploma almost. And together, you qualify as an independent practitioner. So a lot of the time, and many people have tried to get rid of the MEd because the arduous task of working as a doctor, doing calls, studying for exams, preparing, does take a lot of time, and then you're still having to do a massive research project in the form of a master's, especially in the smaller universities where you're not having a lot of oversight and supervision, can be very, very difficult. And so they've tried to get saying, listen, maybe we should go back to the old system and only have the fellowship. But a lot of the big universities are actually against that because one, and I'm going to go straight to the jugular here, is that it's a costly degree. People spend up to 18,000 rand a year to do it. So I find the university is very reluctant to get rid of that extra income that they're getting from students having to pay such a lot of money. So that's another talk on its own. I don't know. I think at some point in time, I think the smaller universities and what we've discussed at a college council level, when we're talking all our HODs from our respective universities in plastic surgery, is that we are very willing to become mentors of people who are struggling. And a mentor doesn't necessarily have to be from the same university. It can be from a different university. A mentor in a way in that they can assist you and supervise you with your research project. And it's now we've got clear guidelines in our college blueprint document, whereby every year there is milestones that need to be achieved. So the whole system is moving towards work-based assessments, okay, and with entrustable professional activities. So we're using EPAs and WBAs as an assessment on an annual basis. So in a way, the final exit exam will become like a formality in the next few years. So if you've performed very well in your years of training, you get kind of signed off on an annual basis. And that really applies to your MEd as well, because in the first year you expected to have a project and have written up a protocol at least with ethics. And then in your second year, you meant to be collecting the data. And here I assist my students. I get a lot of elective students that come from Germany and from Holland and from the UK, and then I will attach an elective student, a keen one, to one of my registrars and say, listen, you assist this registrar with a collection of data, etc., and with a research project. And in some cases, they go on and become co-authors of a published paper, going forward. Um, I'm not sure whether any of my other universities are doing the same, but this is certainly what I do in trying to assist my registrars with the time factor and with the MEd. And so
Mm.
every year is milestones. So the third year they should have written up a draft, and by the fourth year, the dissertation should be complete. So if you do it, and why people run into trouble is that they start really late with these projects. And nowadays they can't do it at UCT for one, because every single year now I've got to write a progress report, and they have to register on an annual basis, and satisfactory, needs to be ticked. So if you've fallen behind, you get discussed. If you are a registrar at the what we call the specialist training committee, and at the specialist training committee, we identify people who are either 1 week and they need assistance, and they need to have a development program, or and see how they improve. Or if they've fallen behind and they need assistance, we can assist them. So this is there's lots of support that we have at certainly at UCT. I'm yet to find out what the support structures are like elsewhere. But again, to answer your question, it's not unique to plastic surgery. This is in every single surgical discipline, and in other areas of Faculty of Health Sciences where there's a research component attached to your basic training. I
Mm.
know I've gone off and gone to
No,
Mars via.
no, you've answered my question actually.
Yeah,
Question from the floor is asking, I think a question that really speaks to people want to know how do they actually set themselves apart. So they're asking, as an undergrad medical student interested in plastic surgery, what should I focus on to build a strong foundation for the specialty? What makes you stand out? So what makes you be part of the 12 that gets shortlisted? That I think that's what they're asking. How
yeah.
how can you stand out from like undergrad level if you're really determined to
I,
become a
I I
plastic
can
surgeon?
tell you I can tell you straight away. I currently have two students. One is a fifth year student and one is a final year student. Both are doing MSCs, or Masters of Science, which I think is a better degree than an MEd, where they are getting to know how to do research, getting to grips with, but they're doing it in plastic and reconstructive surgery. So they've come to me saying that they love the discipline, that they're interested in the discipline, and they would like to do a research degree. And that goes a long way, because, I mean, if you're applying in a few years' time, and you've got a surgical base, but you've already got an MSc on your name with publications, and then you've done your surgical primaries and your intermediates, you naturally going to have a much better chance of getting a sought after registrar post than someone who just comes with a lot of experience and the basic surgical exams. So these students are ones that are thinking ahead, and in any event, even if they decide to go and do orthopedics, for instance, that MSc is still going to stand them in good stead. So I would say that yes, you can do something. It won't necessarily guarantee you a position, but someone who's got a research degree with publications, we're very much going the way of the developed nations now. If I can say, the so-called developed nations, in the UK, you can't apply for a registrar position without at least having 5 or 10 papers on your name already. So there's a student in the UK at the moment. He's Nigerian born, moved to London with his parents, and then came here as an elective student. And me and him have written now 3 papers together, and we've got another fourth one coming. My ideas, but he's written the papers, so he's the primary author, and pretty soon I'm going to get him an interview with an esteemed university in the UK, and he can chase his dream. So yeah, I would say that's the way to do it. I think it's becoming, especially when the disciplines are very competitive. I think if you can get research under your belt, it would be very, very helpful and supportive in your quest to train in that area.
Yeah, thank you so much for that, Prof. I think last question before I let you go. Post-qualification, because of course in this platform we cater from people in all levels, from undergrads to junior doctors to registrars about to finish as well. Post-qualification, navigating that path as well in terms of setting yourself like going into private, because the struggle now is that most people struggle to get admission rights into like most private hospitals. What would be your personal advice to post-qualification doctors in terms of navigating that post-qualification transient phase and establishing, reputable practices if they don't get jobs even in public, because it is a thing. We just don't
No,
have enough
yeah.
jobs even for
No,
consultants.
no, I hear you. I hear you. I can tell everyone here that you'll never have difficulty in private practice in this country at the moment as a plastic surgeon. We are in demand. There are too little of us. In fact, the entire Plastic Surgical Society only comprises of about 215, 220 people, as opposed to ENT, which is probably around 2,000 people, So we're the smallest discipline by far. The majority of us are concentrated in the Gauteng area and in the Western Cape, where there's in excess of 50, 60 plastic surgeons. And I can tell you, they're all busy and working. So there's definitely a demand for us to train, and we need to train more plastic surgeons. But the problem arises that the majority of you that do qualify, even if you have an academic stream, unfortunately, the way the country is structured at the moment, over 80% or closer to 84% of trained people are working in private practice. And that's simply because, like Queen is saying, there aren't any state academic jobs available. And so 16% of the trained people are actually based in the hospital, and that needs to change. And I agree 100% with Aaron Matsoledi that we need to change. We need to create opportunity. We need to up the state academic institutions, because we are the factories. We are churning out and we are training the individuals that are actually servicing our communities. So we need to primarily be focusing on improving, not in cutting. And what we've seen over the years, unfortunately, and it's a reality, we had to cater at the primary healthcare level. And so what happened there was a lot of the budget needed to be extracted from academic medicine. And so we've lost out. But now, if once we've plateaued, we need to readjust, and we need to create funds, and we need to channel that into state academia, etc. And how we've survived over the years is, and a lot of you will know about the monies that were taken away from us now, like in research, training grants, etc. With Trump coming in, we were surviving from overseas support. I myself, in my career, I survived a lot on NGOs and overseas funding, taking sponsored trips overseas just for higher education, etc. So we've had to come up with very innovative ways in academia to survive. And I think as South Africans, we're extremely innovative, if I can say it. We make a plan, and and that's what how is. But we need to actually, the people in power need to empower things like healthcare, education, the basics, which they haven't done well, I'm afraid, in the last few years. So, but to answer your question, we don't have that issue in plastics because we are still in the minority. We are still very sought after. And because we cater for pop culture and, we've become extremely glamorous for the right and the wrong reasons. And for what I showed you in that talk initially was the wrong reasons. But we still at that cutting edge. We have to. One of the big questions that was raised not so long ago was someone said to me, that you guys are being invaded by the other specialties. So ENT, for one, overseas established a discipline called facial plastic surgery, and the eye surgeons established oculoplastics, and the orthopedics now are establishing orthoplastics. And what they're doing is they're stealing from plastic surgery because, we're such a big, vast discipline. And my answer to that was, we can't stop it. It's the way of the world, but we just need to be better at how we do things. And we need to be, and that's what drives the speciality. We constantly need to be above the line, and breaking barriers, and moving forward, and people chasing us instead of us chasing them. So I'm not sure if I answered your question fully, but yeah, it's a field like no other, and for many years people of privilege kept it a secret because they didn't want it to be exposed. In fact, I was the first person of color to train in plastic surgery, certainly in UCT. And at that stage in 2001, there was a memo from government saying that 20% of all trainees in certain disciplines like orthopedics, plastic surgery, anesthetics needed to be transformed. And this is how it started. And so now, when and women were especially underrepresented in plastic surgery. In fact, in prior to 2000, we only trained one woman in the field. Now, if you look at my current registrar, out of the 9 registrars, 7 are women. And this is how we move forward. It's time for change. It's time for, and one of the UCT's objectives for 2030 is not only excellence but transformation, and so we have to keep it up.
No, big ups for that transformation. When you speak transformation, you speak in my language. I love what what you do in your department, but not only that, but UCT as a whole. One last question, Prof. I know we
Yes,
are eating away of your time, but
no problem.
Kwesi is asking if you do have any research opportunities that side for someone who's not currently necessarily in UCT as a way for them to get that research experience.
How do they go about it? Well, I would say that, Tween, you need to put my contact details on your website if you have one.
Okay.
I'm sure you do,
Mhm.
and say that they need to contact me or Rabia Alexander, Mrs. Alexander, my PA, with regards to their requests. And we will certainly try, and I never reject or turn down opportunities outside of the university. In fact, on my staff complement, I have honorary staff members. I've increased my honorary members from other universities where they have scarce skills. So I've members from that qualified at I'm going to struggle to say it, Sefako Mahato, is it?
Sefako Mahato.
Yeah, Mahato. That's it. I couldn't say it earlier. I'm getting it. I'm getting coming close. Sefako Mahato, SMU. I should say just SMU. So
Just
I've
say
got
SMU.
honorary members from SMU, from Wits University, and I've even got honorary members from Bristol as well as Amsterdam University that I collaborate with, and from Harvard. So they currently we run external lecture series where I have them lecture to my registrars and to my undergraduate electives. So we get external teaching. In fact, at the end of this year, I'm hosting a World Congress in Cape Town on cleft lip and palate surgery. It's the second Pan-African Summit. The inaugural one was held in 2024, where we have all world leaders coming to Cape Town, and sharing in not only the experience that we have to offer in terms of tourism and entertainment, but they're coming and they empowering us with the education and teaching, and we have there's about 7 or 8 simulation workshops. So I'm doing a lot in terms of simulation at the moment because we've reached capacity at our training institutions. We have limited time. You can't train people very well on live patients, because we have limited time. So how do you train them? So now we're starting to develop simulation models that are very close to the tissue is mimicked. We have skin, muscle, bone, etc., and you can do actual surgery on these models, and then we actually score these candidates. And once they pass the course and they are accredited, we can actually get them to do their first surgeries on live patients. But we can't do it knowing the risks and knowing the limited opportunities. So we've had to move and think out of the box. So I'm doing a lot in terms of simulation now, and using AI, online teaching, etc., so that we can take it forward. Yes, it's very challenging, but I think this is the way forward. I can't see it any other way. It's just we need 2 and 3 Red Cross hospitals, and we only ever have the one, and we've got an expanding population, and we've got the whole of Africa that's moving in. So yes, it's exciting, but the demand completely outstrips the supply. And so how do
Mm,
you manage this? So you've got to use what you have in terms of innovation, and AI is one of that.
yeah.
Yeah.
Yeah, no, Prof, from the bottom of my heart, from everyone who joined in the talk, for anyone who would be willing to have you as a mentor, of course, I know you'd be open to that. I'll definitely share your details. And yeah, I must say this has been a very empowering talk, and I'm so impressed with the work that you're doing that side already. And
Mm.
yeah, honestly, yeah, thank you so much for taking time out of your very busy schedule. I know you're very busy to come and speak to us and teach us a thing or two. Yeah, no.
Yeah, I hope it came across that we as plastic surgeons should be first and foremost about function, and then only about form. And that unfortunately, in today's world, the glamour and the eccentrics of plastic surgery is really what makes us so popular. But the irony is that 90%, like I said, of what we train to do is reconstructive surgery, which is really the basis and the foundation of modern cosmetic surgery. And I'm not trying to write down cosmetic surgery. I think we do wonderful things there too. Every single politician, movie star, actress, actor nowadays are receiving some or other form of rejuvenation. Everyone, nobody can, we all want to live forever, but we won't. But yes, you can improve on your quality of life. You can improve on your appearance, and certainly whatever does it for you should be available to you. So to end off, I will say to you that again, we are, I believe, at the frontier. We are innovative. It's an exciting field, and for those of you who are privileged to join, my very best wishes to you, and feel free to reach out at any time. And thank you very much for this platform, and thank you for the opportunity, Queen. And I hope you stay strong. And at any time in the future, if you do want to reach out again, please feel free. Thank you so very much.
Yeah, We'll definitely keep in touch, Prof. Thank you so, so
Okay.
much. Thank
All the
you
very
so, so
best to
much.
everyone, and don't be too scared to reach out for your dreams. Okay, it does come
Yes,
true sometimes. All the
yes,
best, everybody,
absolutely.
and thank you, and have a wonderful evening for further.